शेड्यूल से टाइम निकाला और हमारे एक्सपर्ट्स पैनल्स में शरीक हुए। आपका सबका बहुत बहुत दिल से खैर मकदम करती हूँ और आपका शुक्रिया अदा करती हूँ। आप सबकी मौजूदगी हमारे लिए हौसला अफजाई का बाइस बनेगी और आपकी जो एक्सपर्ट्स ओपिनियन होंगी उनसे मुझे उम्मीद है कि हम सब लोग मुस्तफैज होंगे। साथ ही मैं डॉक्टर मोहसिन, अपने मॉडरेटर और कन्वीनियर डॉक्टर सना तौफीक का भी तहे दिल से वेलकम करती हूँ। ये वर्कशॉप की जो मेहनत है वो इन दोनों की बहुत ज़्यादा मेहनत है, एक टीम वर्क है, इसके बगैर हम कोई काम नहीं कर सकते हैं, तो मैं इनका भी तहे दिल से वेलकम करती हूँ। इसके साथ ही साथ जितने भी पार्टिसिपेंट्स हमारे कंट्रीज से और हमारे अपने बैरूनी ममालिक से जुड़े हैं, हमारे साथ डिफरेंट कंट्रीज से जुड़े हैं, मैं उनका भी तहे दिल से वेलकम करती हूँ कि आपने हमारा साथ दिया और हमारी इस वर्कशॉप को कामयाब बनाने में जुड़े हुए हैं। थैंक यू सो मच। इसी के साथ वर्कशॉप के बारे में मैं ज़्यादा नहीं बोलूँगी, क्योंकि ये वर्कशॉप से रिलेटेड सिर्फ इतना ही कहूँगी कि ये डर्मोस्कोपी जो है स्किन यूनिट का एक बहुत अहम हिस्सा है और इससे ये एक डायग्नोस्टिक टूल है। इससे बगैर डर्मेटोलॉजी के बगैर जो है स्किन डिपार्टमेंट को सक्सेसफुल करना मैं समझती हूँ कामयाबी का हासिल नहीं होगा। तो इसी के साथ आज जो हमारे एक्सपर्ट्स यहाँ पर मौजूद हैं, हमारी जो लेडी डॉक्टर्स यहाँ मौजूद हैं, मुझे उम्मीद है कि उनकी जो नॉलेज हम लोग आज शेयर करेंगे, आप सब के साथ वो हमारी अपनी नॉलेज को शेयर करेंगी, तो वो हमारे लिए आने वाले वक्त के लिए हमारा बहुत ज़्यादा उससे हम लोग बेनिफिट लेंगे और इसके में ज़रूर हम कामयाबी हासिल करेंगे। दूसरी इस बात की तरफ मैं आप सब लोगों को तवज्जो दिलाना चाहूँगी कि जो एक हमने एसोसिएशन बनाई है जिसको यूनानी डर्मेटोलॉजी एंड कॉस्मेटोलॉजी एसोसिएशन ऑफ इंडिया के नाम से जाना जाएगा, उसका रजिस्ट्रेशन तकरीबन मुकम्मल होने की स्टेज पे है और इस एसोसिएशन को बनाने का मकसद जो है वो यही है कि जो स्किन डिपार्टमेंट में हिंदुस्तान में और बैरूनी ममालिक में भी जो काम हो रहा है वो सब मंजर आम पे आए और इसका रजिस्ट्रेशन, इसके रूल्स एंड रेगुलेशन जब ये मुकम्मल हो जाएगा तो हम इंशाल्लाह आपको डिफरेंट मीडिया के ऊपर आपको ज़रूर हम पहुंचाएंगे। और मैं उम्मीद करूंगी और आप लोगों से रिक्वेस्ट भी करूंगी कि आप सब लोग इस एसोसिएशन का मेंबर हो और इंशाल्लाह इस एसोसिएशन के मकसद के तो हमारा खास मकसद रहेगा वो ये रहेगा, जितना भी हम स्किन पे काम कर रहे हैं, चाहे वो यूनानी पॉइंट ऑफ व्यू से कर रहे हैं या मॉडर्न टेक्निक के साथ कर रहे हैं, उन सब को हम एक दूसरे के साथ शेयर करें, एक दूसरे के साथ उसको बताएं कि हमारे यहाँ ये काम हो रहा है, हमारे यहाँ ये काम हो रहा है, और हम सब उस काम को मंजर आम पे लाएं और स्किन को जो है वो हम ज़्यादा से ज़्यादा उसके दर्जात को उसको उस डिपार्टमेंट को हम एक ऊंचे मुकाम तक ले जाएं, चाहे यूनानी नज़रिए से हो, मॉडर्न टेक्निक के ज़रिए से हो। और मैं ये चाहूँगी कि और रिक्वेस्ट भी करूँगी कि इस एसोसिएशन के तहत हम जगह जगह कॉन्फ्रेंसेस करना करेंगे ताकि हम अपनी नॉलेज जो हमने अपने ज़रिए से हासिल करी है या आप लोगों के ज़रिए से हासिल की है वो हम लोगों तक पहुँचाएं। तो मैं ज़्यादा टाइम ना लेते हुए मैं इसको कहूँगी मोहसिन, डॉक्टर मोहसिन को इस वर्कशॉप को आगे बढ़ाएं। एक दफ़ा मैं फिर अपने जो डायनेमिक यहाँ पर मेरी डॉक्टर्स मौजूद हैं जो इस इसको डर्मेटोस्कोपी के बारे में बात करेंगी, मैं उनसे रिक्वेस्ट करूँगी कि प्लीज़ अपने अपने ख्यालात का, अपने अपने ओपिनियंस का हमारे साथ इज़हार करें। और एक दफ़ा मैं वाकई बहुत मुझे खुशी है कि वो बहुत शॉर्ट नोटिस पे हमारे साथ आई हैं, बहुत बहुत मैं उनका शुक्रिया अदा करती हूँ और दिल से, तहे दिल से मैं अपने डिपार्टमेंट की तरफ से, अपने यूनिट की तरफ से उनका खैर मकदम करती हूँ। थैंक यू सो मच।
थैंक यू मैम, थैंक you very much. Now, without any further delay and intervention, I would like to connect you all with our learned speakers. Our first speaker is Dr. Susmita Kumari. She is young, dynamic, and budding dermatologist of Mumbai and had a lot of academic and clinical credentials. I request Dr. Susmita to take on the topic Introduction of Dermatology and its utility in the diagnosis of skin diseases. Dr. Susmita, please.
Yes, sir. Sir, can you please give me the permission to share my screen
Of
because,
course. Yes, ma'am.
yes, sir. It's still showing host disabled participant screen sharing.
Okay, okay, ma'am. Just
Yes, sir.
stop video, put on mute. पूछो पूछो कि भाई मैं शेयर नहीं करी जी सलाम किसका पासवर्ड DZE DZE जी DZE E 676 D for dog, D for Delhi, Z for zebra, जी E 676 7 6 Just a minute, ma'am. Sorry for inconvenience.
Yes, sir, please.
Hossein,
Yes, sir.
मुझे भी जाना है, मैं दो शब्द कह दूं।
बस सर 1 मिनट मेरे से ये शेयर हो जाए बीच में इंटरप्ट
अच्छा अच्छा
Yes, sir. Yes, sir. So, good morning, everyone. Myself, Dr. Sushmita Kumari, and I'm thankful to all the organizing committee members for inviting me to speak on the topic of dermatoscopy and its utility in dermatoscope. So we all know stethoscope is a very important instrument for the physicians for the clinical diagnosis of various heart, lung, and abdominal disorders. In the very same way, a dermatoscope is a rapid and safe diagnostic tool which helps in the diagnosis of various dermatological disorders. And so it is rightly called that dermatoscope is a dermatologist's stethoscope. Now, moving on to know what a dermatoscope is. So, it is a non-invasive diagnostic tool which visualizes subtle clinical patterns which are not normally visible to the unaided eye. It has also been called a skin surface microscope, epiluminance microscope, or episcope. Skin surface microscopy was started by Kohlhaas, and then the modifications were done by different scientists like Ernst Abbe. He added immersion oil for better visibility. Johann Safir, he added built-in light source. And Goldman coined the term dermoscopy. Now, how a dermatoscope works. So it works on the principle of transillumination of the lesion and its magnification to various times with the use of various lens applied to the device. Whenever a light falls on the lesion, it is either reflected, refracted, or absorbed by the lesion, and the characteristic features of the lesions can be seen by the observer. Now, this visibility depends on the nature of the skin. If the skin is scaly or dry, then the visibility is impaired. But if the skin is soft, moist, and supple, then the visibility is increased to many times. So, for increasing and improving the visibility, we apply linkage fluids to the contact plate of the dermatoscope. Now, commonly used linkage fluids are liquid paraffin, which is easy to obtain, safe, and it does not have any side effect. Earlier, immersion oil was used, but then it contains chlorinated paraffin and it becomes teratogenic. So now the use has been stopped. Antiseptic solution and water can also be used, but they evaporate very quickly from the skin. So liquid paraffin is the most preferred linkage fluid. Now, whenever we talk about the design or the base, how a dermatoscope is, so it contains a achromatic lens with generally 10 times magnification, but this magnification can be increased by using different type of lens to the device. Then it has an inbuilt illuminating system, which has halogen lamps. With the halogen lamps, they impart yellow color to the lamp, and the lamps are inclined at an angle of 20 degrees to the handpiece of the device. Then we can also have light emitting diodes, which give intense white light to the lesion, and they consume 70% of less energy than the halogen lamps. And also the illumination of the dermatoscope can be increased or decreased by switching on and off the set of light emitting diodes. Now, these light emitting diodes are also available in different colors so as to increase the penetration of the light in the skin and to improve the visibility, because we all know that the penetration of light in the skin is directly proportional to its wavelength. Then we have a power supply, which are through the batteries or through a rechargeable handle provided with the on the dermatoscope. Then some of the dermatoscopes have additional features, like they have an inbuilt photography system which can be by the camera, and also they have software where we can analyze the image obtained through the dermatoscope. Then there are the types of dermatoscope, like first is the basic dermatoscope without any image capturing facility, which is Delta 10. But this can be converted into an image capturing dermatoscope by connecting it to a camera through the adapter. Then we have instruments with image capturing facility like Derma 20, where the camera is inside the dermatoscope. Also, we can have a whole body photography with the use of Mole Max 1. Then we have video dermatoscope, where a high resolution camera is fitted to the device. And we have instruments with image capturing facility and analytic capability, which is generally used in Western countries where the chances of melanoma is high. And the old images of the diagnosis and the new image of the patient, they both can be compared, and any significant change in the lesion can be noted. Then also the dermatoscope, they have polarized lights or non-polarized lights. The polarized lights, they have the advantage that they can be used without contacting the lesion, and they go deep into the structure of the skin. So the deeper structures are easily and very nicely visible. The non-polarized lights, they have to be always in contact with the lesion, and only the superficial structures of the skin are nicely visible. So these are some of the dermatoscopes we use. Like the first is Delta 20 dermatoscope. And when talking about its part, we can see in the first diagram where a Delta 20 dermatoscope is there, which are with a rechargeable handle. B is the lens part of the dermatoscope. Then C is the connector ring through which any device can be connected to it. The D is photo adapter. E is the camera. And below we can see two F and G images, which are the contact plate of the dermatoscope, G being the smaller one and F being the bigger contact plate. Then the second image here is a Dermlight dermatoscope, which is a pocket-friendly, ergonomic, very easy to handle and easy to clean dermatoscope. This has both polarized and non-polarized light system. So the visualization of vascular and pigmented structures becomes very easy. Then the second photograph over here is a Dermafort, where a camera is attached to the dermatoscope. Then here in this slide, the first image, we can see a video dermatoscopy being done. And the second image, we have a Dermlight Photo X lens. This is a universal dermoscopy lens, which can be attached to any device, your smartphones, iPad, any device, it can be connected. And it has both polarized and non-polarized light, and it can be used with the contact of the lesion or without the contact to the lesion. And the brightness level can also be increased or decreased. Now in this slide, we see a specific and dermatoscope, which is mainly used for nail dermatoscopy, and that is a Nailio. Here a stand is there to which the Dermlight Photo X lens is attached. And this is a red color, as we can see in the slide. The red color light is LED is there, with the advantage being that the red light, the penetration is deeper. So the deeper structure of the skin, the distal part of the nail, and the capillaries all can be studied using this type of dermatoscope for nails. Also, this dermatoscope can be tilted from side to side. So we have a wide angle of study. So throughout the nail, we can move it and the study becomes very easy. Now, the dermoscopes which are available in India are Dermoscope, which has 10 times magnification. It is a non-contact type dermatoscope with 4 LEDs. Then we have Mini 2000 dermatoscope, which also has a 10 times magnification, and it is a contact type of dermatoscope. Then we have Delta 10, Delta 20, Dermlight Platinum dermatoscope, which gives us a magnification up to 160 times. And then we have Dermlight 100, Dermlight Photo dermatoscopes. Now talking about the technique of dermatoscopy. So there are two techniques of dermatoscopy. One is contact, where the contact plate of the dermatoscope has to be in contact with the lesion to study the characteristic features of the disease. Now these plates are made up of multi-coated silicon glasses and they can be graduated or non-graduated. The advantage of graduated being that we can measure the dimensions of the lesion. Then, as we have said that the contact technique, the contact plate has to be in contact with the lesion. So the chances of nosocomial infection increases. And so we have to sterilize it using 2% glutaraldehyde, methylated spirit, boiling or autoclaving. In contrast, the non-contact technique, the chances of infection decreases, but the illumination and resolution is slightly impaired. Now talking about why dermatoscopy is used in dermatology. So mainly the dermatoscopy was used for the evaluation of pigmented skin lesions, but now the use has been increased and it is widely being used in evaluation of non-pigmented skin lesion, endodermoscopy, trichology, onychoscopy. So here I'll be taking a few characteristic points of commonly seen or the conditions where dermatoscopy is generally used for. The detailed findings would be taken up by the follow speakers. So in evaluation of pigmented skin lesions, like in melanoma, we can see that the thickened and darkened area, the blue veil appearance can be seen. Then pseudopods, brown dots, they can be seen in the image, the first image. And in the second image, this is of pigmented BCC, where we can see absence of pigment network, arborizing vessels, and pink color is seen. Then it is also used in seborrheic keratosis. Here we can see brown finger-like projections on the side of the image. Then we can see multiple milia-like cysts in the image. We can also see hairpin blood vessels and fissures around can be seen. Then dermatofibroma, here we can see central white scar-like patch and absence of melanocytic features. Nowadays, dermatoscopy is very much widely used for trichoscopy. And when we do a dermatoscopy of a normal scalp, we can see red loops, perifollicular pigment network, and follicular unit having 2 to 3 terminal hair and 1 to 2 vellus hairs. The common conditions where in scalp where dermatoscopy is used is alopecia areata first. Here in the first image, we can see the yellow dots on dermoscopy of alopecia patch. Then in the second image, that is the B image, we can see the tapering and broken hairs. The third image, we can see the black dots. And in the last image, we can see exclamation mark hair. It is also used in androgenetic alopecia, where we can easily see the peripilous sign in the first image with empty follicles. Then in the second image, we can see difference in diameter of the hair shaft, which is very much typical of androgenetic alopecia. Then we can also see small vellus hair growing on the forehead of the patient. Then it is also used for calculation of follicular density in donor area before follicular hair transplant. It is used in telogen effluvium, tinea capitis, where in the image we can see the corkscrew hair or the coma-shaped hairs. And then we can also use it in hair shaft deformities like monolithics, where we can see beaded appearance of the hair with pyritoty where the flat concretions on the hair shaft can be easily seen. Now it is also used in onychoscopy, like in malignant melanoma or nail matrix melanoma, where the longitudinal dark brown black streaks on the nail plate can be seen. And in the B image, we can see the Hutchison sign, that is the pigmentation of the nail folds in nail matrix melanoma, that is also quite easily visible. It is used in onychomycosis, where the proximal jagged end of the nail can be seen, and the onycholytic materials also can be seen. Then it is used in inflammatory skin disorders like in lichen planus, where the typical pearly white Wickham stria can be easily seen. Then in psoriasis, where the red dots are seen. In infectious disorders like molluscum contagiosum, where large globules, white globules can be seen inside the lesion, they are the molluscum bodies. And in scabies, where we can see delta wingjet sign, where we can see the head of the dense part, where the scabies mite is there with a burrow following it. Then in pigmentary disorders also we use it quite often, like in vitiligo we use, and in progressing vitiligo we can see leukotrichia with perifollicular depigmentation in the second image. And in C and D image, that is a repigmenting vitiligo, where we can see perifollicular hyperpigmentation with erythema and telangiectasia in the last image. Then in melasma, where with the white arrow we can see light to dark brown pseudoreticular network, and with the black arrows we can see multiple brown and to black dots all over the melasmic area. Now, when talking about the benefits, so it is a very simple office procedure, and we can easily conduct it when the patient arrives to us without any delay, and with the characteristic findings, we can have an idea about the clinical diagnosis of the disease. When talking about the melanoma, where it is most commonly used initially, so it increases the sensitivity of the diagnosis without decreasing the specificity. It reduces the number of unnecessary biopsies to be taken, and it allows digital surveillance and monitoring in patients with multiple atypical nevi. And it is useful in diagnosis and differentiation of non-melanocytic benign and malignant tumors. Now, we all know that nothing comes with only benefit. Limitations are always there with everything. So is true with dermatoscopy. So first, the limitation is the diagnostic accuracy of dermoscopy is always variable. It totally depends upon the experience of the observer to interpret and to see what he's seeing as the feature of the disease. Then it may fail to recognize melanomas that lack specific dermatoscopic criteria. And in melanoma, it alone cannot establish the diagnosis of the disease. Histopathologic examination will always have to be carried out. So with this, I would like to finish off my presentation. Thank you so much.
Thank you, Dr. Smita. You have covered all basics in detail and in a lively manner. It will definitely be a fruitful for our participants to understand the topic further. Before taking our second speaker, I would like to take the comments of our principal, Professor Saud Ali Khan Saab. Despite of his busy Sunday, he has spared the time for us. So I would like to take on his remark on the topic, and then I will further proceed for the other speakers. Professor Saud Ali Khan Saab.
Thank you. My dear panelists, friends, and distinguished panelists, Dr. Anuja, Dr. Saban Sari, Dr. Susmita, Professor Shakir Jamil, Professor Jamal Akhtar, Professor Azhar Hussain, Professor Zamir Ahmed, and the convener of this workshop, Dr. Mohammad Mohsin, Associate Professor of this very department, It is my pride privilege to be part of this e-workshop on dermatoscopy. I personally, and on behalf of Ajmal Khatibia College, welcome you all on this occasion. I will, I'm sure that deliberations of this e-workshop will definitely boost the scope of Amraz Jild and Zohravia through dermoscopy and the latest advancements in this field. Uh, this is a, a very good initiative of the Department of Amraz Jild wa Zohravia that continuously they are going uh, after short intervals to update the knowledge of Unani system of medicines to the physicians and dermatologists of the other disciplines. Since our institution is about almost 100-year-old institution and imparting education in the Unani system of medicine, and you must be aware that in our Unani system of medicine, the scope of dermatology and the treatment and very successful treatment of lot of skin disorders is already available, which I think you must share with our experts. In the last, I again congratulate to all the participants, welcome all the participants, and wish a successful workshop. Thank you very much.
Thank you, sir. Thank you very much. Now I have another budding dermatologist of Mumbai, Dr. Sabah Ansari. She is an assistant professor, Department of Skin and VD, TN Medical College and BYL Nair Hospital, Mumbai. She has expertise in dermatology, clinical and cosmetic dermatology, and have lot of credential in his field. Dr. Sabah, it's over to you, please.
Hello, Assalamu alaikum. Hello, am I audible? Good morning, everyone. My skin is visible to all? Okay,
Yes.
okay.
Yes.
Okay, I thank everyone for invitation as a speaker to me. I'll be mainly speaking on how dermoscopy can help us differentiating various dermatological disorders. The main highlight, the Dr. Sushmita has already highlighted the main dermoscopic features of certain dermatological disorders. As she rightly said, it is a simple, reliable, and easy to use a technique. Basically, it is a link between macroscopic skin lesions, what we see with naked eye, and the microscopic histopathological features, but that requires us to take skin biopsy. Which is usually not possible in all the cases, especially children, apprehensive patients, and those who are not giving consent. So in such cases, if we do the dermoscopic features can help us to differentiate between various dermatological disorders. So first one is the differentiation between hypertrophic lichen planus and prurigo nodularis. Both these conditions are chronic inflammatory disorders. So clinically, we can see that presentation is quite similar. Both these conditions have hyperkeratotic plaques on lower extremity mainly. Prurigo nodularis clinically can have excoriations also. Dermoscopic features are, in case of hypertrophic lichen planus, we can see the peripheral striations. Then we can also see the brownish black globules Also, bluish gray globules we can see, which are the highly specific feature for hypertrophic lichen planus. Then other findings like comedo-like openings, then yellowish structures. These are also seen in hypertrophic lichen planus. Whereas the dermoscopic findings of prurigo nodularis includes a white starburst pattern. Here also we can see peripheral striations. Then we have pearly white areas. Then the important findings in case of prurigo nodularis are presence of red dots and red globules. Scaling can also be seen. Similarly, here also we can see red dots and red globules scaling. Then this is the pearly white area and also the peripheral striations. Now, what are the points which will help us to differentiate between these two conditions based on the dermoscopic findings and the dermoscopic findings and their histopathological correlation? The first one is the peripheral striation with pearly white area. In case of hypertrophic lichen planus, these are arranged only peripherally and only in some areas. Whereas in prurigo nodularis, we can see a central white area with peripheral extension which involves the entire lesion. So it gives a starburst appearance. And histopathologically, this peripheral striation with pearly white area corresponds to compact orthokeratosis above a wedge-shaped zone of hypergranulosis, acanthosis, and dermal fibrosis. Next finding is comedo-like openings, which is mainly seen in case of hypertrophic LP, and it represents transepithelial elimination. It is usually not seen in prurigo nodularis, and histopathologically it corresponds to follicular dilatation, plugging, and hypergranulosis of the follicular infundibulum. Next is blue-gray globules, which is very specific finding for hypertrophic lichen planus as it is not seen in case of prurigo nodularis, and it histopathologically corresponds to presence of pigment-laden melanophages in the dermis, and it suggests that the lesion is regressing. So it is a good sign. Next is yellow structures, which is seen yellow structures and brownish black globules. These two are seen only in hypertrophic lichen planus, not seen in prurigo nodularis. Yellow structures basically they correspond histopathologically to spongiosis and vacuolar degeneration of the basal cell layer. Whereas brownish black globules represents melanocytes in the epidermis on histopathology. Next is red dots, which are basically the clusters of dotted vessels, although they are also seen in lichen planus, but only during the active phase of lichen planus. As we know, hypertrophic lichen planus is either subacute or mainly chronic form of lichen planus. So in hypertrophic lichen planus, red dots are not seen. They are seen in significantly higher numbers in prurigo nodularis, and histopathologically they represents dilated capillaries. Then we have red globules. Globules are usually larger than the red dots. Also, these are not seen in hypertrophic lichen planus and prominently seen in prurigo nodularis, and they represents enlarged blood vessels as well as focal hemorrhage seen in the dermis. Next is the other chronic inflammatory disorders which clinically presents with similar findings like erythema, scaling and itching mainly on the scalp or face. So also based on the dermoscopic findings, we can to an extent we can differentiate these two between these two conditions, rosacea and seborrheic dermatitis. So this image is showing the dermoscopic finding of rosacea, where we can see it is important to look for the background color, then the type of vessels, its distribution. So here we can see that the background has a dark red color, and we can see a network-like pattern of arborizing vessels. This is the dermoscopic image of seborrheic dermatitis, where we can see that the background is slightly pinkish, orangish, pinkish. We can see few dotted vessels. These are the dotted vessels and yellow patchy scales. These are the yellow patchy scales characteristic of seborrheic dermatitis. Next, if a patient present with this uh, clinical morphology, we can have multiple differential diagnoses, like it can be psoriasis vulgaris, it can be lichen planus, it can be pityriasis rubra-pilaris. So depending on the clinical patient's history, depending on the extent of involvement, other findings like findings on scalp, nail findings. But dermoscopy can help us to differentiate between these papillosquamous disorders. So while evaluating a case of inflammatory disorder, we should look for vessels, then background color, type of scale, then other findings. So vessels, we should look for the how is the vascular arrangement, whether they are regularly arranged in clusters, in patches, peripherally arranged. Then how is the vascular morphology? Vessels are dotted, linear, or both dotted and linear arrangement. Then background color also give us clue what may be the underlying etiology. Then type of scale, color of scale, distribution of scale, whether it is diffusely distributed or it is centrally distributed or only peripherally attached. Then other specific findings like presence of white crossing streaks known as Wickham striae, which is characteristic of lichen planus. So all these findings can help us in differentiating various papillosquamous disorders. So the first clinical picture where we can see the well-defined erythematous scaly plaques. So dermoscopy showed white scales. These are the scales. Then dotted vessels. The important point here is that these vessels, dotted vessels, are regularly arranged, which is a very important finding for psoriasis. Then the background is dull red in color. So this is a case of psoriasis. Again, a case of psoriasis here, clearly we can see the dotted vessels, how regularly they are arranged, and the characteristic silvery white scales also. Next is a case of in this case the dermoscopic findings are we can see the radial streaming of the whitish Wickham striae. These are the Wickham striae. Then we can see here the short linear vessels, and the background is slightly violaceous. So this is a case of lichen planus. Next, here we can see the dotted vessels, and we can also see follicular plugs, and the background is yellowish or maybe yellowish and orangish. So this is a case of pityriasis rubra pilaris. Next is different types of dermatitis. It may be irritant dermatitis, maybe frictional dermatitis, maybe lichen simplex chronicus, lichen planus, prurigo. So dermoscopy again can help us in differentiating various dermatitis or lichenoid dermatitis. So here in this dermoscopic image, we can see there are patchy dotted vessels, not regular in distribution, and we can see the brownish scales, and the background is faint red. So this is a case of dermatitis. Next one, we can see the perifollicular scaling. Then there are whitish structureless areas. Background is pigmented, and we can see the broken hairs of different length. So this is a case of lichen simplex chronicus. Next is hypertrophic lichen planus or lichen planus hypertrophicus. Here we can see multiple comedo-like openings. We can also see these are the corn pulse-like structure. Then again becomes striae and a violaceous background. So this is a case of hypertrophic lichen planus. Next one is here we can see a central erosion, a starburst pattern, again a pearly white area with peripheral pigmented dots. So this is a case of prurigo. Next, this is a presentation of palmar scaling erythema. So we can have differential diagnoses like tinea menum, palmar psoriasis, or hand eczema. So this is showing brownish globules, then yellowish scale crust. Here also we can see yellowish scale crust. Then these are the patchy dotted vessel, and the background is faint red in color. So this is a case of hand eczema. Next is palmar psoriasis. So again, even in case of palmar psoriasis, we can see uh, regularly arranged red dotted vessels. And next is tinea menum. In case of tinea menum, we can see the whitish scales and dotted vessels also we can see, but they are present mainly in the skin furrows. So this is because the dermatophytes, they are predominantly localized to the skin furrows. So as an inflammatory response to these dermatophytes present in the skin furrows, there will be dilatation of the blood vessels. So here also in case of tinea menum, we can see dotted vessels. But in case of tinea menum, dotted vessels will be mainly localized to the skin furrows, and the scales will be also localized to skin furrows. Where as in case of psoriasis, as I said, the scaling will be diffuse and dotted vessels will be regularly arranged. Next, again, patient presented with erythema and scaling with involvement of only one hand with sparing of the right hand. So on dermoscopy, we can see the scales mainly localized to skin furrows, and on polarized dermoscopy with immersion fluid, where we can better visualize the vascular structures. We can see the dotted vessels, which are mainly localized to the skin furrows. So this is also a case of tinea manum. So these are basically again the how to dermoscopically how we can differentiate between these three conditions. In chronic hand eczema, you can see white scales which will be sparse, then yellow zero crust and organized dots or globules can be seen. Palmar psoriasis scales will be diffuse with regularly arranged dotted vessels. They can be Bushian glomerular capillaries also, and tinea manum scales and dotted vessels localized to skin furrows. Next group of disorders is granulomatous disorders. Again, we can have different differentials here: lupus vulgaris, sarcoidosis, granuloma annulare, necrobiosis, lipoidica. So, dermoscopy can help us again in these disorders also. So here dermoscopy is showing the yellowish white background. We can see whitish streaks, and also we can see comedo-like openings. So this is a case of lupus vulgaris, which is a form of cutaneous tuberculosis. Next is necrobiosis lipoidica. Here we can see a prominent network of the linear arborizing vessels. And the background is yellowish in color. So this is a case of necrobiosis lipoidica. Next is here we can see dotted linear vessels, then whitish areas, and background may vary from white to red to yellow color. So this is a case of granuloma annulare. Next is orangish yellow globules or areas we can see along with the linear vessels, and this is a case of sarcoidosis. Next group of disorders is inflammatory facial dermatosis. So differential diagnosis here based on the clinical morphology can be discoid lupus erythematosus in this case. It can be dermodicosis, it can be rosacea. Now rosacea can be a typical case of rosacea, or it can be topical steroid induced rosacea. So dermoscopy of these lesions, in this case dermoscopy showed follicular plugging, then perifollicular whitish halo can also be seen. Then we can see the follicular red dots and whitish scales. So this is a case of discoid lupus erythematosus and connective tissue disorder. Next is we can see all these are dilated hair follicles, but in some of the dilated hair follicles, we can see some yellowish structures, which are basically the yellowish tails of the demodex mite. So this is a case of demodicosis. Also, we can see some curved short vessels. Next is here we can see curved short vessels, these pigmented blotches, and hypertrichosis. The number of hairs uh, is increased. So this is a case of topical steroid induced rosacea. So basically, the side effects of steroid, topical steroid, we can see hypertrichosis, hyperpigmentation, telangiectasia. Now, this is a typical case of rosacea where you can see the polygonal vessels without any evidence of hypertrichosis. Now, next group of disorders I will be discussing is the skin tumors, the malignant ones. The first one is the basal cell carcinoma. So, dermoscopic findings which help us in diagnosis of basal cell carcinoma include absence of pigment network, along with that presence of at least one of the criteria, which includes ulceration, maple leaf-like structure, blue-gray globules, blue ovoid nest, arborizing vessels, and spoke wheel structure. So we'll see each feature of BCC one by one. So first one is the absence of pigment network, which is must for the diagnosis of BCC on dermoscopy. So here we can see there is no pigment network. Also, we can see the blue-gray globules, which is a specific finding. Then here we can see the focal ulcerations, and this is the white structureless area. Next, the dermoscopic findings, and again the histopathological correlation. So here we can see ulceration and crust. This is the ulceration and crust seen on dermoscopy, and histopathologically here also we can see ulceration and crusting. Next is maple leaf areas, because it resembles a maple leaf. So we can mainly it is seen in the micronodular type of BCC, where we can see there are nodules with the pigment which are connected to each other by the lobular extensions. Next is again it is showing a maple leaf like structure. Next is blue-gray globules. Here we can see multiple blue-gray colored globules. Basically, they represent the small tumor nest. These are the tumor nest within the dermis with central pigmentation. So when we have structures like this on histopathological examination, on dermoscopy, they appear as blue-gray globules. Next is ovoid nest. These are the ovoid nest. So again, they are the tumor nest with pigment aggregates in the dermis. Then arborizing vessels. They are large dilated vessels in the dermis. Here we can better appreciate the arborizing vessels. They are bright red, thick vessels around 0.2 mm or more in diameter, and they are branching and giving rise to terminal capillaries, which are fine with a diameter of 10 microns. So these are seen in BCC, but this is not a specific feature of basal cell carcinoma because it is seen in other conditions also. Then this is a structureless area, which basically represents the stromal desmoplasia. Then we have spoke wheel-like structure. Basically, they are well circumscribed brown, gray, blue, brown colored radial projections, which are meeting at a darker brown central hub. So these are the spoke wheel-like structure. And histopathologically, they are pigmented aggregates of basal cell carcinoma that emanate from the undersurface of the epidermis with multiple projections into the dermis. And this finding is highly specific for basal cell carcinoma. So, in a nutshell, this is the diagrammatic presentation of dermoscopic features of basal cell carcinoma. So, we can see spoke wheel-like areas, which is a specific finding. Then, large blue-gray ovoid nest. We can see ulceration, arborizing vessels. Then, multiple blue-gray globules, leaf-like areas. So this can help us to know what is the type of BCC, whether it is micronodular, superficial, but the limitation is that the extent of the disease cannot be evaluated on dermoscopy. Again, now the pigmented, coming to the pigmented lesions of skin. So there are different patterns. Some of the patterns are seen in benign lesions like melanocytic nevus, Spitz nevus, and the other lesions are seen in malignant pigmented skin lesions like melanoma. So patterns like reticular, globular, cobblestone, homogeneous, starburst. These patterns are seen in benign pigmented skin lesions, whereas parallel pattern, multi-component pattern, non-specific pattern, these points towards the malignant skin lesions like melanoma. So this is a reticular pattern. Here we can see the globular pattern, multiple tiny globules clustered together. Here we can see the cobblestone pattern. Here the larger globules are clustered together. Then we have homogeneous pattern. All these are mainly indicating the benign pigmented skin lesion. Then we have starburst pattern, then parallel pattern, which may point towards a melanoma, and we have a multi-component pattern. Next is how to, based on the dermoscopic findings, again, how to differentiate between benign and malignant lesions. So if the pigment network is typical, it is benign. If it is atypical, it is melanoma. Dots and globules, if regular, benign. If they are irregular, then it indicates melanoma. Streaks, again, regular indicates benign and irregular indicates melanoma. Then blue whitish wheel regression structures, these are specific dermoscopic findings for melanoma. Now, hypopigmentation may be present as a non-specific finding. Then we have to look for blotches. If blotches are symmetrical, benign, asymmetrical, melanoma. Any asymmetry points towards melanoma. Any atypical finding, any asymmetry, irregularity. So this is also a dermoscopic finding that helps to differentiate benign from malignant lesion. So it is known as radial streaming pseudopods or streaks. Basically, they are projections, radial projections of dark pigmentation at the periphery of a lesion that radiates from the tumor. Histopathologically, they correspond to the confluent junctional nest of melanocytes, and they indicates that the lesion is of melanocytic origin. Now, if these pseudopods are arranged circumferentially around the entire perimeter of the lesion, then it points towards a benign pigmented lesion like Spitz nevus. But if the streaks are located focally at a perimeter, only at one perimeter of the lesion, then it is indicative of melanoma. So here in this lesion, it is suggestive of melanoma because it is only focally arranged in some area of the lesion. These are the pseudopods. Next is the blue-white veil. So this bluish hue, which we can see, is representing the blue-white veil. Basically, it has some overlying ground glass-like haze also, and haziness is there, ground glass haziness. It is basically aggregation of heavily pigmented melanocytes and melanophages in dermis, along with the overlying epidermal changes. In case of melanoma, the structure will be heterogeneous, prominent, and it will be asymmetrically placed, whereas in case of nevi it will be homogeneous with a light hue located mainly towards the center of the lesion, but it can also be seen in seborrheic keratosis and pigmented BCC. But if it is heterogeneous, prominent, and asymmetrically placed, it is specific for melanoma. Then again, based on the anatomical site, the findings that can differentiate benign from malignant lesion. So typical pseudo network indicates benign melanocytic nevus if it is annular, granular structure. Pseudo network is gray in color. There are rhomboidal structures. Asymmetric pigmented follicles are present. Then they points towards melanoma. Then palms and soles, if there is a parallel furrow pattern, lattice-like pattern, fibrillar pattern, then they are suggestive of acral nevus, and melanoma is indicated by presence of parallel ridge pattern. So it is important, even if it is parallel, it is important to look how is the pattern, whether it is furrow pattern, whether it is ridge pattern. Now there is something called as ABCD criteria for diagnosis of the malignant skin lesions. So after capturing the dermoscopic image, we can edit the image, and the ABCD criteria is basically A is for asymmetry. Here we have to draw two perpendicular lines, and in basically we have to look for the symmetry of the lesion, and symmetry takes into account the contour, the colors, the structures within the lesion, and based on that we have to give points to whether it is symmetry or not. Like if both the axes are symmetrical, the lesion is symmetrical in both the axes, then 0 point is given. If it is showing asymmetry even in one axis, then we give 1 point, and if it is asymmetrical in both the axes, then we give 2 points. So the point for asymmetry ranges from 0 to 2, maximum will be 2 points. Then again, for evaluating the border sharpness, we have to divide the area into 8 pie-shaped pieces. And in each piece, we have to look for the border sharpness, whether it has an abrupt perimeter cutoff or not. And based on that, each piece is given a point of 1 point is assigned to each piece. So total point ranges from 0 to 8, maximum will be 8. Third one is C. In ABCD criteria, C is for color. So we have to look for the color, whether it is light brown, it is dark brown, it is blue gray or black in color. So 1 point has been assigned to each color, light brown, dark brown. So total point ranges from 1 to 6. Next is the dermoscopic structure. So we have to look for dots, we have to look for globules, we have to look for the structureless homogeneous areas, the network, and the branched streaks. And the total point ranges from 1 to 5. So then we have to calculate the total dermoscopic score. This is a formula for calculating the total dermoscopic score, and the score ranges from 1 to 8.9. So this is the interpretation based on the scores. If it is less than 4.75, then it points towards a benign lesion. 4.75 to 5.45, then it is suspicious. And if it is more than 5.45, then the lesion is likely to be a melanoma or a malignant lesion. Then we have another scoring system for differentiating benign from malignant lesion. So we have few positive features and few negative features. Positive features include blue white wale, multiple brown dot pseudopods, scar-like depigmentation, multiple colors like variegated appearance, then broadened network. Negative features include the pattern is symmetrical and only single color is present, then it is a negative feature. So if for melanoma to be diagnosed, that lesion must have none of the two negative features and one or more of the 9 positive features should be present for the diagnosis of melanoma. Next is a 7 point checklist for differentiating. So we have certain major criteria and minor criteria. Major criteria includes atypical pigment network, blue white wheel, atypical vascular pattern, and each one has been assigned 2 points. And minor criteria includes irregular streaks, irregular dots, globules, and irregular blotches. So for the diagnosis of melanoma, we require a total minimal score of 3. If it is less than 3, then it is indicative of a benign nevus. Now, coming to other skin tumors like squamous cell carcinoma. So this is a case of well-differentiated squamous cell carcinoma or a keratoacanthoma progressing to SCC. So here we can see the white keratin masses. We can see the white circles and white clots. Clots are basically structures which are larger than the globules, and they vary in size and shape as compared to globules which are usually circular. We can also see the polymorphic vessels in the center. So presence of polymorphic vessels is suggestive of a malignant skin lesion. Next is a actinic keratosis, facial actinic keratosis, which is a pre-malignant condition. Here we can see the pink-red pseudo network. Basically, there are the vessels which are present between the hair follicle openings, and the central keratotic plugs also can be seen. So basically, this creates a pattern reminiscent of a strawberry. So it is known as a strawberry pattern of facial actinic keratosis. Now, next, we will discuss the disorders of pigmentation. So mainly the hyperpigmented ones. So these two are the cases of vitiligo, this depigmented patch, and this is a depigmented macule present on the ankle. Dermoscopy can help us to assess the disease activity in case of vitiligo, whether it is active, whether the vitiligo is stable or unstable. This is a pattern called as polka dot appearance, where multiple small depigmented patches or macules are present. So this indicates in a polka dot arrangement. So this indicates that the vitiligo lesion is unstable. Then next is we can see a white structureless areas and perilesional pigmentation we can see. Also we can see this satellite lesion. Clinically, the satellite lesion represents copnerization. So this is known as a comet tail appearance. This is also indicative of an unstable vitiligo. Next, so there are main four dermoscopic patterns which are suggest of unstable vitiligo. The first one is the trichrome pattern, where we can see 3 colors. This is a normal pigmentation, this is the hypopigmentation, and this is the depigmented area. Then as I described, this is a comet tail appearance. Then this is a starburst appearance, and then polka dot appearance. So all these dermoscopic patterns are suggestive of unstable vitiligo. Next is a condition which is due to age-related changes called as idiopathic gutted hypomelanosis or IGH. So it also presents with depigmented macules, mainly in elderly patients, mainly on the lower extremities. So it can help us to, dermoscopic findings can help us to differentiate this from vitiligo. So now we have 4 different patterns. One is amoeboid pattern, petalloid pattern, feathery, and nebuloid pattern. Amoeboid pattern is basically, we can see a depigmented patch with relatively well-defined margins, which are sending out the pseudopod-like extensions, like here. So this is an amoeboid pattern. This is the petalloid pattern, like a petal of a flower. Here we can see a well-defined depigmented patch which has a pigmented polycyclic borders. So these two dermoscopic patterns are seen in two conditions. One is idiopathic gutted hypomelanosis and stable vitiligo, but it is more commonly seen in case of idiopathic gutted hypomelanosis. The next two patterns are feathery and nebuloid. Feathery is depigmented patch with feathery margin, and nebuloid is a depigmented patch which has irregular margins. And we can see that the margins are indistinctly merging with the surrounding pigmentation. So this is a nebuloid pattern. These two patterns are also seen both in stable vitiligo and idiopathic gutted hypomelanosis, but they are more specific for stable vitiligo. Next, coming to the infectious dermatological disorders like wart. So usually we need to differentiate between wart and the callosity or corn. So dermoscopic feature of a wart will be like this, multiple dots, which basically represents the pinpoint hemorrhage. Next is molluscum contagiosum. Contagiosum. This is the clinical presentation. Umbilicated pearly white papule. We can see the central umbilication. So dermoscopically, as Dr. Sushmita described, we can see a characteristic central amorphous yellow clot, which is typically seen in the center, representing the HP bodies. And we can see the peripheral arborescing vessels against a white background. Next is scabies. Again, this is a scabies mite, the head of a scabies mite, and this is the burrow. So this is known as a jet with contrail sign. And this is a dermoscopic feature of lichen planus pigmentosus, where we can see that hyperpigmented dots and specks are arranged in a hem-like pattern. This is the hem-like pattern. So we can see basically histopathologically this represents that the in case of lichen planus pigmentosus, we can see pigment incontinence histopathologically. So because of that, there will be presence of multiple melanophages in the dermis, which are mainly perivascular in location histopathologically. So they appear as ham-like pattern on dermoscopy. Next is a benign skin tumor, that is dermatofibroma. So there will be a delicate peripheral network. There is a central scar-like area, and between these two, between the delicate network and central scar-like area, we can see the ring-shaped globule. So this is a case of dermatofibroma. Next is pityriasis rosea. Here we can see that on dermoscopy there is no vascular pattern, and characteristic colorate scales also we can see. So this is a case of pityriasis rosea. So this is how dermoscopy can help us in differentiating various dermatological disorders, particularly useful in children, those not giving consent for biopsy. So because it is a non-invasive tool in apprehensive patients, also we can use dermoscopy. And also it can reduce the frequency of unnecessary skin biopsies, but it needs practice. You should know what are the different dermoscopic findings for a particular dermatological disorder and how you can differentiate it from other differential diagnosis for a given clinical picture. So yes, it can help in diagnosis and differentiating the dermatological disorders. Thank you. These are my references. Thank you.
Thank you, Dr. Sabha. Muted or not? Okay. Is it YouTube or sorry? Thank you, Dr. Sabha. You have nicely covered the applied aspect of dermatology with reference to dermatoscopy in a very lively, elaborative, and yet comprehensive manner. Thank you very much.
Thank you, sir.
Dear participants and colleagues, now it's a turn of our third important speaker, Dr. Anuja Sunkwad. She will cover the trichoscopy and nail dermatoscopy. Dr. Anuja is a consultant dermatologist at Bhabha Hospital, Bandra, and a visiting dermatologist at SAI Hospital, Chembur, Mumbai. Dr. Anuja, it's over to you to take on, please.
Hello everyone and good afternoon to all. I'm going to share my screen just for a moment. Hello, is it visible to all?
Yes.
Hello.
Yes, ma'am, you are audible. My slide is visible quite.
Good afternoon everyone. So by this time we have already seen basics of dermatoscopy and common cutaneous conditions under dermoscope. So I'll be covering hair and nail dermoscopy, that is trichoscopy and onychoscopy. So under trichoscopy, I'll be covering following conditions like alopecia areata, AGA, tinea capitis, telogen effluvium, ETM, LPP, DLE, scalp psoriasis, and few genetic conditions like trichorexis nodosa and monolatrix. First of all, we'll be seeing alopecia areata. So this is a clinical picture of localized alopecia areata, a well circumscribed hairless patch over a 10-year male child. These are some other variants of clinical variants of alopecia areata, totalis and ophiacis pattern. What will we see of alopecia areata under dermoscope? So there will be exclamation mark hair, short hairs, fractured hair, multiple polycyclic yellow dots and black dots. Most sensitive marker for alopecia areata is yellow dot and short vellus hair. The specific marker would be black dots. The marker of disease activity would be black dot again, and the marker of severity would be black dots combined with yellow dots. So this is the trichoscopic feature of alopecia areata, showing multiple black dots and few tapering hair. In this slide, you'll be seeing exclamation mark here. These are multiple exclamation mark here and yellow dots, multiple numerous yellow dots. Here again, multiple black dots. So the pictures would be different depending on the severity of the patient. Like black dot type would be more severe, yellow dots and exclamation marks would be the specific ones for diagnosing purpose. Here is a patient with treated alopecia areata. You can see the difference between two slides. Like one is showing multiple black dots, exclamation mark hair, vellus hair, and tapering hair. And in treated case, you won't be seeing any black dots or any other hair related findings. So coming to the next condition, which is androgenetic alopecia. The most specific finding in androgenetic alopecia would be hair shaft diameter variability, and the diameter variability has to be more than 20%. The second thing is yellow dots, small bald areas with numerous empty follicles, peripyla sign, scalp pigmentation due to the sun exposure, and variation in the number of each follicular unit. The one thing which I already told, that more than 20% variability is the typical finding of androgenetic alopecia, and it is usually seen in early phases. And the percentage downgrades with the treatment. So these are the few patterns of alopecia. These are male pattern baldness, female pattern AGA, frontal hairline recession, and Hamilton grade 4-5 vertical thinning, and it's a female pattern AGA. These are the clinical pictures, and on dermoscopy we'll see hair shaft diameter variability. Like we can see few hair are having normal hair shaft and few hair are having uh, uh, diameter variability. Like few will be vellus hair, few would be anogen hair. Here also we can see diameter variability. Like many hair would be vellus and many would be the anogen hair. Here also you can see appreciate very well in this slide. The hair shaft diameter variability is almost around more than 30 to 40% in this case. So what will we see? The trichoscopy is not just for diagnosing AGA, it is also for assessment of patient after treatment. So if a patient is having like this type of AGA and is getting better with treatment, like he's improving his frontal hairline like this. So his trichoscopy would also show you the improvement, like his hair shaft diameter variability will reduce and his hair shaft would be getting uniform hair shaft diameter. So the next thing is tinea capitis. These are the clinical variants of tinea capitis, like gray dot pattern, gray patch, black dot, chirion, favors. So on trichoscopy, you would see corkscrew hair, zigzag hair, comma hair, and broken hair. In this picture, you are seeing a corkscrew hair and a zigzag hair like this, and multiple black dots also. Here in this slides, you are able to see broken hair. That was about tinea capitis. Next thing is telogen effluvium. So telogen effluvium is basically a diagnosis of exclusion. There is no characteristic dermoscopic feature for this. Absence of there is no any absence, no any hair diameter variability which rules out AGA. So you need to know the other trichoscopic findings to rule out telogen effluvium. If hair diameter variability is absent, then AGA is ruled out. If follicles are preserved, that rules out cicatricial alopecia and other like corkscrew or comma hair, which rules out some infectious conditions. So it's basically a diagnosis of exclusion. You won't see any, you will be seeing just thinning of hair, sparsity of hair, but without any characteristic finding. Next thing is trichotillomania. Trichotillomania, there are many findings which are described in literature for trichotillomania. One of them is a V sign, which is commonly seen, and perifollicular hemorrhage, which is also seen in more than 80% patients. The other things are like flame hair, uneven lengths of hair, and coiled hair shafts. So this is the V sign, the breakage of the hair shaft in a vertical manner, and these are the perifollicular hemorrhages. Because of continuous pulling of hair by the patients, it causes perifollicular hemorrhages. This is also the variable lengths of hair. This is also another finding of trichotillomania, because the patient pulls hair from a specific site, but the lengths become variable because the patient doesn't pull it from a specific site. So the variable lengths of hair you will be seeing even clinically and as well as on the dermoscopy. Next thing is lichen planopilaris. Characteristic clinical picture is like this. It's shiny, irregular, it's not a well circumscribed lesion like that of alopecia areata, but it's a irregular one, but it is completely hairless, shiny, atrophic, and the edges have the maximum activity. So the trichoscopic findings of LPP are peripilar cast, follicular plugging, perifollicular pigmentation, exaggerated pigment network in interfollicular areas, and white dots. White dots represent fibrotic bands, fibrosis, because of the chronic, it's a chronic condition, so it becomes atrophied and shows as a white dots. We can see perifollicular plugging and cast. The cast will appreciate better in this slide. It's a tubular cast around the follicular plug. Here again, you can see perifollicular scales and perifollicular plugging. This is a tubular scaling in LPP. This is one more thing, a target pattern of follicular infundibula. Next thing is differentiation of scalp psoriasis versus seborrheic dermatitis. In scalp psoriasis, because of the dilated papillary vessels, we may see homogeneously tortuous dilated capillaries in the psoriasis. Whereas in seborrheic dermatitis, tortuosity would be less because there is no any dilatation of the capillary loops, and the seborrheic dermatitis would be is a isolated there would be isolated dilated capillaries, and here would be multiple dilated capillaries. This is a psoriatic homogeneous dilatation of the capillaries. And this is seborrheic dermatitis. We can see yellowish scales with fewer dilatation, but not with the preservation of the local microangio architecture. Another thing is DLE, discoid lupus erythematosus. So there would be branching capillaries, white patches, keratin plugs, reduced follicular ostia. This is again a cicatricial type of alopecia. So we will be seeing reduced follicular ostia with keratin plugs and white dots, as we have seen in LPP. But the specific finding of perifollicular plugging, which was shown in LPP, would not be here in DLE. Another two genetic conditions I have included are trichorexis nodosa and monilethrics. This is the schematic representation of trichorexis nodosa. It is because of defect in hair. These are both the defects of hair shaft. So in trichorexis nodosa, longitudinal split in the hair is seen, which appears as a two brushes of end aligned in opposition. And in monilethrics, alternating nodes with internodes, and they are equally and regularly spaced. So the trichoscopy of trichorexis nodosa would show multiple breaks in the hair like this, and the appearance of two ends of brushes aligned in opposition is seen very nicely in this picture. And another thing is this is also multiple breaks, like hair would have many fractures, multiple fractures in a single hair shaft. And this is monilethrics, beaded moniliform appearance of the hair shaft with nodes and internodes regularly spaced nodes and internodes. So these are the common conditions which I have covered under the heading of trichoscopy. Now we'll be heading towards onychoscopy. Dermoscopy of nail apparatus is known as onychoscopy. Onychoscopy facilitates visualization of the nail plate, nail bed, nail folds, nail matrix, vascularity of the nail bed and periungual tissue. In a way, onychoscopy, since we all know the nail biopsy is very tedious job, so the onychoscopy provides submicroscopic observation of the nail features and thus bridges the gap between naked eye examination and histopathology. And in a way, it may reduce the burden of doing nail biopsy. So we should be very thorough for onychoscopy, because the nail biopsy is a like, it's not like skin which will get healed within 7 to 10 days. The nail biopsy injury would be like for many days. So under the onychoscopy, I'll be covering normal vasculature of the nail apparatus, nail fold capillaroscopy, and capillaroscopy patterns in connective tissue diseases, nail psoriasis, nail LP, nail in alopecia areata, periungual warts, and longitudinal melanonychia versus nail melanoma differences. So coming to normal nail vasculature, there are two digital arteries going laterally in the fingers and forming a hairpin loop like structures. So this is a very uh, characteristic finding of the nail vasculature. that it forms an anastomosis in a pattern of a hairpin loop. Capillary loops are formed at the distal part. So, what is the need for doing nail fold capillaroscopy? So, many systemic conditions like Raynaud's phenomena, systemic sclerosis, mixed connective tissue diseases, and dermatomyositis and SLE show various nail fold capillaroscopic findings. So, to differentiate between these connective tissue diseases and to assess their prognosis with the treatment, that is the importance for NC. So, Raynaud's phenomena may be present in patients of scleroderma, like from months to years before the skin changes appear, and it simulates primary Raynaud's phenomena. In early stages of scleroderma, histopathology may be inconclusive. So, for early stages, onychoscopy would be a better choice of diagnosing early stages of scleroderma. Presence of abnormal vasculature pattern in these patients indicate potential for development of connective tissue disease in the future. And patients of primary Raynaud's phenomena should undergo careful, that's why the patient should undergo careful capillaroscopic analysis every month to rule out underlying connective tissue disease. Coming to nail psoriasis, just a moment. My nail fold capillaroscopy got erased. These are the normal capillaroscopic pattern. So normally we can see regularly placed capillary loops along the nail fold with a regular diameter of the capillary loops. The density of capillary loops is equal, almost 30 capillaries per 5 mm of the nail fold. And there are no any architectural derangement. This is a normal capillaroscopic pattern of a normal person. So what are the so we have seen the so we should be thorough with this normal capillaroscopic pattern so that we can find the abnormal patterns. Abnormal patterns are giant capillaries, hemorrhages, loss of capillaries, that is avascular areas in nail, and areas of angiogenesis and architectural disorganization. So first we'll see one first abnormal change in vasculature is giant capillaries. Giant capillaries are formed because of abnormal angiogenic response to a peripheral ischemia. So these are the giant capillaries. They form a homogeneous and irregularly enlarged microvasculature loops. So you can see these are the normal capillary loops, and these three are the giant capillary loops. These are the abnormal ones. So the giant capillaries are the earliest and striking feature of the secondary Raynaud's phenomena. Here we can see giant capillaries, and only a single one or two are only normal. Rest of all are abnormal, that is giant capillaries. Next abnormality in microvasculature is a microhemorrhages, also known as splinter hemorrhages. So these are associated with the early vascular damage. Direct injury to the it is caused because of direct injury to the capillaries by ischemia or perfusion, seen in Raynaud's phenomena. There are dotted lined hemorrhages at the periphery of the capillary. Single hemorrhages may be found in a healthy person, whereas plural, like multiple, one or two lesions could be because of underlying hematoma. But if a person is having multiple splinter hemorrhages, then that is because of underlying systemic condition, and it is more specific to the systemic scleroderma and dermatomyositis. These are some other microhemorrhages I'm showing you. Avascular areas. Avascular areas are because of dropping out of the capillaries. The capillaries over there are lost. So the decrease in number of loops, that is less than 30, which was the normal thing was more than 30 in 5 mm of diameter. And the decrease in number of loops less than 30 is the abnormal one, which will show us on the onychoscopy as a avascular area. Patients with severe capillary loss frequently develop intractable skin ulcers, progressive loss of capillaries, extensive skin involvement. It's a poor prognostic sign. Avascular bands, and it's a main culprit for development of digital ulcers in multiple connective tissue diseases. So here we can see the patient is having digital ulcers, and his patient's onychoscopy is showing complete loss of nail fold vascularity, that is avascular areas, white fibrotic bands. Desert, it is also called desert-like appearance on a nail fold microscopy. Next is angiogenesis. The two might seem opposite, like vascular areas and areas of angiogenesis, but the pathology behind the two is the same. There is abnormal angiogenic response to a peripheral ischemia and highly tortuous, bushy, arborized capillary loops. These are the arborized capillary loops. They are often they are nearby the vascular area. So the area near few areas are showing white fibrotic bands, completely avascular area, and one or two areas are showing arborizing vessel. This is because of abnormal angiogenic response to the peripheral ischemia. This is seen in late stages of ramified capillaries in systemic scleroderma. This is arborizing vessels in a late stage pattern of systemic scleroderma. Some architectural derangement, like capillaries are not seen as loops or hairpin-like structures, so they form a U shape or striking. This is a striking modification of a normal architecture. It is seen in early phases of Raynaud's phenomena, actually unilateral or expressed in a single finger. This is also architectural derangement, arborizing vessels and U shape. Other patterns of nail fold capillaroscopy in systemic scleroderma, the stages of systemic scleroderma depending on nail fold capillaroscopy are early stage, active stage, and a late stage. So in early stage of systemic scleroderma, we may find few giant capillaries, few capillary hemorrhages with well preserved capillary distribution and no evidence of loss of capillaries. The loss of capillaries will be seen in the late stages. Here we will be seeing only few dilated capillaries, one or two giant capillaries, otherwise normally distributed capillary loops. So this is an early pattern of systemic scleroderma. Another photograph of early pattern. The capillary loops are relatively well spread, but few dilated capillaries can also be seen. So the active pattern will have many hemorrhages and many giant capillaries comparing to that of early one. So loss of capillaries won't be there, but we may see loss of capillaries, which will tell us that it might go into the late stage of systemic scleroderma. Mild disorganization of the capillary architecture, absent or few ramified capillaries. So the splinter hemorrhages and giant capillaries are numerous. Other findings would be they might be there, or otherwise they could be absent. So this is an active pattern showing multiple splinter hemorrhages. Coming to the late pattern of systemic scleroderma, absent of few giant capillaries and hemorrhages. Only one or two giant capillaries we are able to see. Otherwise, there is no any normal capillary loop is visible around the structure, and complete loss of vasculature here. Extensive avascular areas, marked disorganization, and ramified and bushy capillaries can be seen. This is a late pattern, ramified and bushy capillaries and loss of capillary network, like here completely avascular areas, 1 or 2 dilated capillaries, and this is the ramified capillary. So what the other capillaroscopic like differentiation is like scleroderma pattern and scleroderma like pattern. The scleroderma pattern is specific for systemic scleroderma seen in more than 95% of patients, and scleroderma like pattern would be seen in dermatomyositis and mixed connective tissue diseases. So this is a typical hand of dermatomyositis showing Gauthron papule, mechanical hand. It will show scleroderma-like pattern. The scleroderma pattern is for just systemic sclerosis, and scleroderma-like pattern is for dermatomyositis and MCTD. This is again SLE, scleroderma-like pattern seen in 2 to 4% of SLE patients. MCTD is again scleroderma-like pattern. Almost 64% of MCTD cases show scleroderma-like pattern, because we already know that scleroderma and MCTD are a group of almost a group of condition. What are the advantages of the nail capilloscopy? It has high negative predictive value for connective tissue diseases associated with Raynaud's phenomena. It's a positive predictive value is only about 50%, but this also has higher than any other single screening test. Assessment of the disease severity in systemic sclerosis, positive correlation between active pattern and visceral involvement. The active pattern of nail fold capillaroscopy is usually associated with other systemic and visceral findings. And in 2001, the nail fold capillaroscopy got added in the minor criteria of American ACR criteria, that is also EULAR criteria. Nail fold capillaroscopy got 2 points out of 30 points of EULAR, and it is one of the diagnostic criteria for systemic sclerosis. So coming to nail psoriasis, I hope everybody has understood nail fold capillaroscopy. It was like very comprehensive, because I only added 20 slides of this. It's a very huge topic. Next thing is nail psoriasis, dilated globose vessels. The onychoscopic findings are dilated globose vessels at onychodermal band surrounded by prominent halo. Splinter hemorrhages as linear purple streak, dilated vessels at the proximal nail fold, reddish-orange area, demarcating onycholysis, and clinically pits, ridges, and surface irregularity we can see. This is the clinical picture of nail psoriasis. We can appreciate the coarse, discrete pits and onycholysis in this, along with splinter hemorrhages and salmon patches of the nail. Visible dilated capillaries along the onychodermal band in a nail psoriasis patient. Again, dilated capillaries are along the onychodermal band. Splinter hemorrhages can also be seen. Appears as a bright red streak. Splinter hemorrhages seen through a contact dermoscope. These are the magnified image of splinter hemorrhages. So onycholysis is seen like this on a nail onychoscopy in a nail psoriasis patient. Pitting is not visualized in a onychoscope in a polarized manner. So we have to apply oil to get a clear picture for multiple irregular pits, to see multiple irregular pits in a psoriasis condition. This is the surface irregularity seen in psoriasis. Clinically seen surface irregularity. Coming to next condition, alopecia areata associated with the nail findings. So clinically apparent nail signs in Pits of alopecia areata are shallow, smooth, uniform in size as compared to psoriasis. These tend to be discrete. Ridges are regularly placed. There would be increased pigmentation in a paintbrush pattern. Coming to next condition, periungual warts. Periungual warts are difficult to treat and usually highly infectious in adults as well as in children. So we need to diagnose it as soon as possible and get it treated. So the periungual warts show hyperkeratotic structures with numerous punctate capillaries and small hemorrhages. Small hemorrhages is a main onychoscopic finding in diagnosing the periungual warts. Next thing is differentiation between longitudinal melanonychia versus melanoma. So this is a clinical picture of longitudinal melanonychia, and this is a nail melanoma, nail apparatus melanoma. So clinically, we can see uniform color throughout the band in longitudinal melanonychia, and proximal nail fold is characteristically squared. Whereas in melanoma, the proximal nail fold is affected, it is pigmented, also known as Hutchinson. On dermoscopy, we can see longitudinal um, the bands are gray in color and there is no much variation in the color. Whereas in melanoma, the color variation, we can really appreciate the color variation. There is brown, pigmentation black, melanin granules are visible. And this suggests the melanocyte proliferation. This is a melanocyte activation. So coming to the summary of my topic, the dermoscopy is a valuable, sensitive, and underutilized tool which facilitates the visualization of the skin, hair, and nail. It provides rapid detection of dermatological disorders with advanced diagnostic accuracy and predicts the course of the disease. And it decreases the unnecessary need for the biopsies. If a biopsy is mandatory, dermoscopy can aid as a assisting active biopsy site. So, thank you all. Have a great day. I hope everybody has gained something from my lecture.
Thank you, Dr. Anuja. Really, you have hit the nail. You have really covered the topics very well and in a very simple, understandable manner.
You told me that day PG students might be attending. So I covered full capillary.
A lot of PG students are there. Actually, ma'am, you could not. I think you could not see the participants. There are participants across the country as well as across the boundary. No, there is no geographical boundary of due to this particular virtual meeting. Participants are from Pakistan, from Bangladesh, Sri Lanka, Bhutan, Malaysia, and Dubai. We got the information through their WhatsApp number. Therefore, nice delivery by all three experts. Now, I will take the remark of our panel members. The most senior person, former director and former director of Central Council of Research in Indian Medicine, Unani Medicine, sorry, Professor Sayyid Shakir Jamil Saab, who is a renowned academician in the field of Unani fraternity, and he has insight on clinical research, applied research aspects, and several feathers in his cap. Professor Sayyid Shakir Jamil for his remark as a panelist. Professor Shakir Jamil, sir, are you listening? Are you? probably his connectivity has gone. I have received a message of Professor Jamal Akhtar, who is the principal of State Government Tibia College, Lucknow. He is in the meeting by Ayush Director, so he may contact may add in our program later on. Now I have Professor Anzar Hussain from Bhopal. Professor Anzar Hussain, who is head of the Department of Dermatology in Tibia College, Bhopal, and he behaves like our young elder brother and patronizes in several programs of skin diseases and our department and so on. I think Professor Shakir Jamil is visible on our screen. If he is able to take on, sir, Professor Shakir Jamil, sir.
Yes, Assalamu alaikum. I have joined again.
You are welcome, sir.
Thank you very much, sir.
You are requested to take on the panelist remark as a senior panel member.
Assalamu alaikum wa rahmatullah. Bismillahir Rahmanir Rahim. First of all, I will very much thankful to the organizers of this beautiful workshop to provide me this opportunity to give my remarks in this event. Respected dignitaries of the Aligarh University, Professor Abdul Mannan Sahab, I do not know that whether he is listening me or not. Dr. Shagufta Alim and all the learned, though they are very young speakers, but I should say because the presentation was very good, all the learned speakers. And other Dr. Anzar, I don't know, he's listening me. I think he's listening me. Dr. Jamal Akhtar, Dr. Zamir, and most of all, Professor Dr. Muhammad Mohsin, who is the organizer of this beautiful workshop. At first, I appreciate and I congratulate Dr. Mohsin and the Department of Amrad Jil, Department of Dermatology, Aligarh Muslim University, for the organization of this beautiful event. As far as the presentations are concerned, all the three presentations are very elaborative and also comprehensive. And I think that will be very much beneficial for the not only for the students but also for the teachers of the dermatology. And at some places, I can say for those persons who are involved in clinical research, because in general, I have been involving in the clinical research in my whole life, so I can't make away myself for the research by any deliberation. Also supported and involved clinical research in any field of Unani medicine. So the presentations are very beautiful, very elaborate. My second point is that I have been always elaborating this point that we should use the technology in the clinical research of Unani medicine, in the clinical practice of Unani medicine. Fortunately, we have been using the modern technology, modern instruments, in the clinical research. We are already using some of the instruments. We are already using some of the procedures. But we should also use this modern technology in clinical practice also. Because the clinical practice, this will benefit not only to create the evidence, not only convince the modern scientific community, including our very aware patient, but it will make more relevant the outcome of the Unani medicine, the benefits of the Unani medicine to the modern society, more relevant. And third and very important benefit of this using of the modern technology is that I'll give some examples also. that this modern technology use will reveal new ideas, new information of the uses of the treatment of some other diseases. For example, a Unani medicine, a particular Unani usul ilaj, Unani treatment, and the drugs have been advised for a particular disease. But when we use the modern technology and we record and we make our observation, we experience that this is also very much beneficial for the other also, and this will help in creating in the creation of the new information, and that will be the asset of that particular physician or the particular researcher, and it will go in his or her account, this new information that can be generated with the use of this modern technology. I'll give um, uh, 2-3 examples, but I'll give one example that we conducted a small clinical study. A small means is with the short sample size in Jamia Hamdard Department of Amrazi Jil, in which uh, we generated the data on a particular disease, that is dandruff. The product was a Unani pharmacopoeial patented proprietary product that is already in the market. We come to know that the product that is indicated for dandruff, but that is more beneficial for hair fall. So this was the new information that um, uh, we have successful to create, and that may be a part of literature, that may be a part of that may be that will be for the more, that will make the Unani medicine more relevant um, for the society. Second thing that we have done in that particular project, that was a properly well on the study was short sample size, but properly more only protocol, well-designed protocol that was approved by the ethics committee. That's what registered in this clinical trial registry of India. The second thing that we have done in that particular study, that we have converted the powder form of that particular product, that was Zulamla, into a shampoo, a paste type shampoo, and that was very easy to use. So with the modern technology, why I mean to say, and we have involved in that study Department of Pharmaceutics of Jamia Hamdard, Professor Farhan Jalis and others. What I mean to say that we have not to use the modern technology in the diagnosis, but also in the conversion of the Unani products more presentable and more user friendly, more presentable and more user friendly. The difference between the previous product and the product that was converted into a shampoo was that is very much easily usable by the patient or by the person. Uh, so the compliance was much better than the previous product. Patient compliance was the much better with the previous patient. So these 3-4 points are related with the use of modern technology. The second point is, I want to submit that despite I am very much strongly organizing that we should use the modern technology in our clinical practice, in our clinical research. At the same time, I am very much, I have very much strong opinion about that we should use the Unani usul ilaj. I mean, we should treatment that should be given according strictly with the Unani principles of treatment, because the drugs, the principles of treatment and the prescription, that is mamulati matab, that have already been mentioned in our literature, and that have the experience of the centuries long experience, that itself is a testimony. Here I want to make one clarification that whatever written in our literature have been written after a very long clinical experience by the Unani physicians. That is not without any experience. Though the problem is that is documentation is not available. That documentation we have to create. That data we have to generate. And for this small sample size study we can conduct. So we should use modern technology in the clinical research and clinical practice. But we should treatment should be prescribed according to principles of treatment of the Unani medicine. I will give one example for this person. I will share one my experience because the issue of the practice. I will share one experience. There was a patient. She was 22 years girl, and she was having this melasma in which is in her face. I was thinking that what treatment should be given that should be maximum beneficial in a very shortest duration, because the young girl was her family members were very much they were very much concerned that she was shortly to be married after few months, 4 or 5 months. I simply started Munzijati Soda, those drugs which are used as a Munziji Soda or cocktail drugs for the black bile. It was also experienced by me that within a treatment of 3 4 weeks, generally we give Muzijat for 3 weeks, then we give Musilak for alternate days for 1 week, then Tabrid. This is the general usul ilaj, general principle of treatment in United medicine. I almost followed that way of treatment, that principle of treatment, simply Muzijati Soda. And it was also a new experience for me that within almost 3 4 treatment, the face patches of the melasma almost removed, and much improvement was there. And you know that if the patient um, get benefit with the treatment, doesn't turn up, if the patient doesn't have any benefit, any use, he or she also doesn't turn up. So I could not make complete follow-up treatment for that patient. So this experience that I have shared, that we should use the Unani Usul Ilaj, Unani principles of treatment, because in our literature and in our experience, the prescription or the treatment is according to Unani Usul Ilaj. So we should use to modern technology and use the Unani Usul Ilaj for the treatment. I'm very much very much thankful to the organizers. One more initiative that has been taken by the Department of Amrad Jil, Department of Dermatology, Aligarh Muslim University. I especially congratulate Dr. Shagufta Alim, Dr. Mohsin, and Dr. Zamir and other members of the department to take this initiative. This is a very good initiative, and that will take very long, long consequences, long effects. I think this will help the collection of the wisdom of the physicians and teachers, researchers all over the country and all over the world. I once again thank and congratulate to organizers and providing me the opportunity for say a few words. Thank you very much.
Thank you, sir. Thank you very much. Now our speakers have to leave. They have their busy schedules and prior assignments. So I request Professor Anzar Hussain from Bhopal for his remark within 1 minute, please. Professor Anzar Hussain, sir. Kindly unmute, sir. Anzar, sir, please unmute. Professor Anzar, you have... Okay, okay. Professor Anzar, you are not audible. Okay, there might be some technical issues. Now I request Professor Shagufta Aleem, the organizing chairman of this virtual workshop, for his concluding remark and vote of thanks. Professor Shagufta Aleem. Kindly unmute, ma'am. Dr. Sabha has already left the meeting because of her prior assignment, and
Hello.
she has requested for the
You
same.
listening me? Mujhe?
Okay, ma'am,
Hello.
you are audible, and kindly take on.
थैंक यू मोहसिन. सबसे पहले तो मैं ऊपर वाले का शुक्र अदा करूंगी कि उसने मुझे एक अच्छी वर्कशॉप करने का मौका दिया, मेरे साथ इतने अच्छे लोगों को जोड़ा, अच्छे स्पीकर्स, अच्छे पैनलिस्ट सबको जोड़ा और अच्छे काम करने वाले. अल्लाह का लाख लाख शुक्र है. इसके बाद में जो हमारे आज के एक्सपर्ट्स थे, जो हमारे आज के स्पीकर्स थे, डॉक्टर सुष्मिता, डॉक्टर सभा, डॉक्टर अनुजा, इन सब का मैं तहे दिल से शुक्रिया अदा करती हूँ. इन्होंने इतना इंफॉर्मेटिव और नॉलेजेबल लेक्चर्स दिए कि आज हमको लगता है कि जो डर्मास्कोप है उसके बारे में, कि वो कितने टाइप के होते हैं, उनसे हम क्या किस बीमारी में हम किस डर्मास्कोप को इस्तेमाल कर सकते हैं, उनका क्या यूज़ है, उनसे कैसे हम डायग्नोसिस कर सकते हैं, उनके क्या क्या फ्यूचर, किस बीमारी में हम उनको देख सकते हैं, इस सब के बारे में जो नॉलेज हमें दी है, वाकई वो एक तरीके की हमारे लिए बेहद कारआमद है, बेहद यूजफुल रहेगी हमारे फ्यूचर के अंदर. इसी तरह जो डॉक्टर अनुजा ने जो लेक्चर दिया ट्राइकोस्कोपी और ऑन्कोस्कोपी के ऊपर, वो भी वाकई काबिल तारीफ है और नॉलेजेबल है. तो मैं इन सब का तहे दिल से शुक्रिया अदा करती हूँ कि आज इन्होंने हमें मुकम्मल डर्मास्कोप के बारे में नॉलेज दी, और मुझे उम्मीद है कि इस नॉलेज से हमारे साथ जितने भी पार्टिसिपेंट जुड़े हैं, चाहे वो डॉक्टर्स हो, प्रैक्टिशनर्स हो, स्टूडेंट्स हो, रिसर्च स्कॉलर्स हो, यहाँ के हों, बाहर के हों, वो सब भी इस नॉलेज से बहुत ज़्यादा उनके लिए ये नॉलेज कारआमद होगी, और अपने अपने फ्यूचर के लिए, अपनी क्लिनिक्स के लिए, अपने हॉस्पिटल्स के लिए, अपनी रिसर्च के लिए, अपने ओपीडीज के लिए, इन सब नॉलेज को वो यकीनन अप्लाई करेंगे और इसका फ़ायदा उठाएंगे. तो मैं तहे दिल से अपने स्पीकर्स का शुक्रिया अदा करती हूँ, और उम्मीद करती हूँ कि आइंदा भी जब जब हमें उनकी ज़रूरत पड़ेगी वो अपनी नॉलेज को हमारे साथ शेयर करेंगे और हमें हमेशा हमारा साथ देंगे. तो तहे दिल से मैं डॉक्टर अनुजा का, डॉक्टर सभा का, डॉक्टर सुष्मिता का थैंक्स करती हूँ, अपने और अपने सारे पार्टिसिपेंट की तरफ से, और अपने ऑर्गेनाइजर्स की तरफ से, जिन्होंने इस वर्कशॉप का को आज इस मुकाम पर पहुंचाया. तो थैंक यू ऑल द स्पीकर्स. इसके अलावा मैं डॉक्टर शाकिर जमील साहब, जो हमारे पैनल एक्सपर्ट्स थे, उनका तहे दिल से शुक्रिया अदा करती हूँ. आपने जो मशवरे दिए हैं डॉक्टर शाकिर जमील साहब, वाकई वो फ़ायदेमंद है. आपका कहना सही है कि हम यूनानी उसूल को मद्देनज़र रखते हुए मॉडर्न टेक्निक्स को अपनाएं तो हम ज़्यादा बेनिफिट ले सकते हैं. मुझे उम्मीद है कि आज का ये जो वर्कशॉप है और इसमें जो नॉलेज हम लोगों ने हासिल की है, वो यकीनन स्किन डिपार्टमेंट के लिए, स्किन के लिए और अपनी फैकल्टी के लिए एक अहम किरदार अदा करेगी. तो मैं सभी पार्टिसिपेंट्स का, अपने सारे एक्सपर्ट्स का, ख़ास तौर से अपने डीन अब्दुल मन्नान साहब का, अपने प्रिंसिपल साहब का, सऊद अली खान साहब का, और सारे अपने फैकल्टी के मेंबर्स जो हमारे साथ इस वक्त वर्कशॉप पर मौजूद हैं, और अपने सारे चेयरपर्सन्स का जिन्होंने अपना कीमती टाइम निकाला और हमारे साथ जुड़े हैं, मैं उन सब का तहे दिल से शुक्रिया अदा करती हूँ. और मैं उम्मीद करती हूँ कि आज की वर्कशॉप यकीनन आपके लिए नॉलेजेबल होगी, आप इससे फ़ायदा उठाएंगे और अपनी अपने फील्ड में इसको इस्तेमाल करेंगे. इसी के साथ मैं डॉक्टर मोहसिन आपका तहे दिल से शुक्रिया अदा करती हूँ, डॉक्टर सना तौफीक का भी शुक्रिया अदा करती हूँ, और अपने डिपार्टमेंट के सारे जो हमारे एम्प्लॉइज़ हैं उनका भी शुक्रिया अदा करती हूँ. क्योंकि कोई भी चीज़ करना है एक टीम वर्क है, बगैर टीम वर्क के हम कोई काम नहीं कर सकते. तो आज जो ये वर्कशॉप हमारी कामयाबी के साथ इख्तिताम पर पहुंची, इस सब में आपका सपोर्ट ना होता तो शायद ये वर्कशॉप ना होती. तो मैं तहे दिल से आप सबका भी बहुत शुक्रिया अदा करती हूँ, और मुझे उम्मीद है कि जो हमने एक एसोसिएशन बनाने जा रहे हैं उसके तहत ہم اس ٹائپ کی ورکشاپ, اس ٹائپ کے سیمینارز کرتے رہیں گے اور اس فیلڈ کو ہم اپنے ساتھ جوڑے رہیں گے. تھینک یو فار آل جو ہمارے ساتھ جڑے ہیں, جو ہمارے ساتھ اس ورکشاپ میں شریک ہیں, چاہے وہ بیرونی ممالک کے ہوں یا ہمارے اپنے ملک کے ہوں. تہہ دل سے ایک دفعہ میں سب کا شکریہ. تھینک یو سو مچ. تھینک یو.
Thank you, madam. Thank you very much. I am highly thankful to Dr. Susmita Kumari, Dr. Anuja Sungwad, and Dr. Sabha. Really, they have delivered very nice talk, and there is 100% delivery. Lot of participants have benefited, and most of them, they were diverted to YouTube channel, and it is available on YouTube, and they could get benefit when they require and where they need. And I'm thankful, Dr. Ma'am and Professor Shagutari ma'am and other panelists of this very important workshop. Thank you all.
ایک بات کہنا چاہوں گی مجھ لاسٹ میں ان کا بھی شکریہ ادا کروں گی اپنی یونیورسٹی کے اس ڈپارٹمنٹ کا جس نے اس ورکشاپ کو آرگنائز کیا اور میڈیا کے ذریعے تمام لوگوں تک پہنچایا. میں شکریہ ان سارے ممبرانز کا شکریہ ادا کرتی ہوں جو اس وقت ہمارے ساتھ ہماری ٹیکنیکل سپورٹ کے لیے بیٹھے ہوئے. تھینک یو سو مچ فار ایوری. تھینک یو.
ایک بات اور کہ ہمارے وائس چانسلر صاحب نے ڈیپلی ریگریٹ کیا ہے کہ وہ بیچارے کسی وجہ سے دہلی ان کا اسائنمنٹ ہوا, ادروائز ہی ہیز گیون کائنڈ کنسنٹ ٹو بی پریزنٹ ہیئر.
میرے پاس وائس چانسلر صاحب کا لیٹر آیا تھا, ان کی کال ان کے سیکرٹری نے کی تھی. آج جو ہیں سر وہ آؤٹ آف اسٹیشن ہے, انہوں نے اس بات کے لیے معذرت کی تھی کہ وہ ہمارے ساتھ نہیں جڑ سکتے, لیکن مجھے امید ہے کہ ان تک یہ نیوز پہنچی ہوگی اور وہ بھی جو فیکلٹی اور یونیورسٹی میں جو آج ہم لوگوں نے ایک ورک شاپ کیا ہے, امید ہے کہ وہ اس سے وہ کافی پرسکون اپنے آپ کو محسوس. تھینک یو سر, آپ کا جو آپ نے ہمیں اس بات کو بتایا. تھینک یو.
تھینک یو.
اب میں اس شکریہ کے ساتھ اس ورک شاپ کو اختتام کا اینڈ کرتی ہوں. اور اللہ حافظ آپ سب کو کرتی ہوں. اللہ حافظ.
Thank you all.